Hello, everybody, and welcome to the final episode of the series from Care Fertility for National Fertility Week. My name is Charles Kingsland, and I'm the Chief Medical Officer here at Care Fertility. And it's interesting. I'm going to tell you all you need to know about IVF, but I'm going to tell you some of the stuff that you probably haven't read on social media. Because if I want to laugh these days, I'd go on social media and look about fertility because there's so much misinformation. Now, you might be surprised to know this, but it's 40 years ago this year, 40 years ago that I walked into my first fertility clinic. Now, you're probably thinking, my word, he doesn't look that old. Well, there's two things. Number one, I was only 12. I was a child prodigy. Not quite true. But two, I moisturise regularly. That's why I maintain my skin complexion. Really? No. I thought you wouldn't believe that. But during those 40 years, I've seen thousands of individuals, couples, same-sex, heterosexual couples. And when I set up my own IVF unit in 1989, which then went on to become the Hewitt Centre. I named it after my best friend who sadly died, John Hewitt, in the early 2000s. I wanted to express the notion that everybody in Cheshire and Merseyside should have access to IVF free at the point of contact within the NHS, and that's what I aim to do. We did very well. We are still underfunded for NHS, but we did better than most. And then at the height of my time there, we were doing 2,500-3,000 cycles. But I left there in 2017 to join Care Fertility, where I am now. So what I'm going to do is just spend about 20-25 minutes talking about stuff that's related to IVF. And where I'll start is, often I say to medical students, what's a disease? Okay, that's what you're here for. You're here to learn about disease. Well, disease, you get lots of different definitions, but actually, if you break down the word, dis in medicine means anything that's abnormal. Dysmenorrhea, funny periods, dysphoria, funny, mental aberrations. Dis means abnormality. Ease is easiness. So disease is an abnormality of easiness. Now, the one thing that I've noticed over the 40 years is that couples or individuals who come in with a fertility problem are ill at ease. They are diseased. So for me, fertility problems is the definitive disease because it's stressful. And why is it stressful? Why do people feel so bad when they can't have a baby when they want one? Well, having a baby, reproduction, is a biological drive. We as mammals have biological drives. We move, we breathe, we grow, we reproduce, we respond to our environment. We eat, we die. Whether you're a baboon, a dolphin, or a human, we all do the same things. Now, that's what we do. And if we don't do it, we panic. So if I said to you, take a deep breath, hold it for 5 minutes, I will guarantee you that in 1 minute, all you'll be thinking about is getting air into your lungs. If I said to you, you can't eat for a fortnight after tonight, this time tomorrow, all you'll be thinking about is eating. If I said, don't move a muscle for 30 seconds, you'll want to twitch in 5-10 seconds time. And in the same way, if I said to you, you can't have a baby and you want a baby, all you think about is babies. First thing in the morning, last thing at night, every second of every hour, of every day, of every week, of every month. And then your mind starts playing tricks on you. All my friends are pregnant and I hate them, but I feel very guilty because it's not their fault. Everybody's pushing a pram. Every shop on the high street has got baby clothes in it. Or as a patient said to me years ago, Professor Kingsland, you could put me in a supermarket, blindfold me, put me in any supermarket in Britain, and I will find the nappy aisle. Because that's how you feel. You feel stressed. It's a stressful situation, like not being able to breathe, not being able to eat, not being able to move. And then, of course, you need treatment. Now, for when do you need treatment? If I took 100 couples off the street and said, I want you to go away and try and have a baby. Let's call them 30-year-olds. After 1 year, when they came back, 70% would be pregnant or have had a baby in the first year. After 2 years, it goes up to about 73. After 3 years, it's 75. But it levels off after a year. So we normally define fertility as inability to get pregnant when you want to be after a year of unprotected intercourse. I think that's wrong. I think it's an ancient definition. And if you're diseased and you can't have a baby and you're ill at ease, go and seek help, irrespective of how long you've been trying. The Americans say 1 year under the age of 35, 6 months over the age of 35. Now, the reason we could use 35 as a cutoff is, and if you've seen my Instagrams, you'll hear it time and time again, the difference between boys and girls is that boys are sperm factories. We have all the ingredients in our bodies to make sperm every day of the week. Some days we've got a tit, some days we're bad at it. But we can make sperm up until the day we die. Increasingly, sperm is poor quality, and for reasons I'm not going to go into today. But that difference between boys and girls is that girls are egg warehouses. All your eggs are in your ovaries on the day you're born. You can't make them. You certainly can't make them better, irrespective of what social media says. You can't make them better. You can only stop them from being worse. And the thing that affects eggs more than anything else is your age. So if a couple come in to me having been trying for a baby for a year or two at the age of 35, and they're a heterosexual couple, the male maybe have sperm that's 2 weeks old. But I know for a fact that the female's eggs will be 35 years old. And that's why the older you are in your fertility journey, the quicker you need to get help. Because we know that of those 100 couples that might want to come and see us, 30 to 40, maybe even more, would benefit from IVF. And the sooner you get to IVF, the better the chance of you of getting success. So infertility is very stressful. It does your head in, and so is treatment. Even though treatment actually is not that bad. The actual treatment itself is not that bad. There are 4 phases. You stimulate your ovaries to make lots of eggs. You collect the eggs, which is actually not a difficult procedure. You make the embryos, and then you freeze them, or you have them one put back fresh and you freeze the spare ones. And that's the embryo transfer. And they're the four stages. So patients will often ask me, what are your success rates? Now, this is the important stuff, because I could say to a patient, seriously, what would you like it to be? Because I will tell you anything, but it will be the truth. Because you can define success in many, many different ways. Now, the HFEA the HFEA are the Human Fertilization and Embryology Authority, are our regulators. And every year, we collect our data, and they look at live birth rates per cycle of treatment started. So the number of babies you get for the number of treatment cycles that have started. And of course, it's different for different age groups, but 95% of the patients who go into that to those success rates, the statistics for 95% of those clinics are the same. So the top 5 have better statistics, and the bottom 5 have got poor statistics, but the vast majority of IVF clinics have the same outcomes. They might vary, but statistically, they are the same, very similar. Because it's not where you go that counts, it's who you are. And there have been lots of trials done looking at success rates from postcodes. There was a very good study done by St. Thomas's and Guy's Hospital, a very big IVF unit in central London, looking at success rates in the different postcode areas of London, and depending on the postcodes, the success rates differ, because different people have different nutritional status, they have different ages, and so there are lots and lots of different factors that go into who you are that make the difference. So where you go for your treatment is important, not only, you know, for success rates, because I've told you that the success rates are very similar, but is it an do you qualify for NHS treatment? Now, NHS treatment is not part of the national tariff, so individual health authorities will fund IVF the way they see fit, and unfortunately, whether we like it or not, and I don't like it, fertility is still deemed as a low priority. If you look at COVID, the thing that was cut, you know, the NHS services that were cut more than any were gynecology, of which the lowest priority in gynecology is fertility, because purchasers would have you argue that the money needs to go to, you know, cancer therapy, diseases of the elderly, mental disease, and of course that's a debate that's been going on for years. There's only so much money to go around, and the one who shouts the loudest gets the money. But generally speaking, most areas, if you've got to fulfill 3 criteria for NHS treatment, and this goes for I know the Liverpool one, because that's where I've spent most of my working life. You've got to be under 42 at the time of treatment. You've got to have a body mass index of under 30. Body mass index is your sort of it's your weight in kilograms over your height in meters squared. So you can't be overweight, because we don't know that weight negatively affects your outcome. And there should be nobody on the planet that calls you mummy or daddy. It doesn't matter if you're same sex or heterosexual, because families are for everyone, irrespective of gender, sex, or race. But they're the criteria. So about 45% will fulfill the criteria for treatment. And treatment normally is 1 or 2 egg collections and the replacement of all the embryos that are created. So do you qualify for NHS treatment? In which case you need to go to your NHS hospital. And if you don't know, your GP will be able to tell you. But if you can't get access, then you have more control, because you're going to have to fund that treatment yourself. So what are the things that are important? Geography is important. You need to go to a clinic that you can get to. There's no point in driving 40, 50, 60 miles down the road when because you've heard that the success rate is 3% more, you know, there than here, because by the time you got there, you're probably stressed to hell. You can't park, you don't know where you are, and the stress levels that you've got may negatively affect your outcome. So geography, where it is, how you can get there, where can you park or not? Is there a public transport service? In my clinic, I felt it very, very important that you can park right outside the door and you don't have to pay, because, you know, if you're going for a stressful treatment and you know, you're already stressed because of your condition, and then you're stressed because you're going for the treatment, what must it be like if you can't find anywhere to park? Or then you know, it's really expensive, you can't find the pay machine, and there's nowhere to park. You've got to be there at 10 o'clock for your scan appointment. All that adds to the stress, and you can do without it. So, you know, go somewhere where you can park, where it's free, where you can walk in to the clinic, you know, in the rain and not get wet. Do you want to go to a big clinic, or do you want to go to a small clinic? Do you want to go to a big clinic that do hundreds and hundreds of cycles, or a small clinic with a more sort of personalised touch? Do you want to go into a clinic where you walk in and somebody will say, "Hello, Alison, Mrs. Smith, Mr. Jones, how are you?" They know you. They provide continuity. Or would you prefer to be more anonymous? There's no right or wrong answer. There's just your answer. And for me is the continuity of care. Will you see the same people every single time, so that people know who you are and will say, I remember you, this is what happened last time and this is what we're going to do next time. Because that for me is really, really reassuring. So you have decided where you're going to go to clinic, whether you're going to have to fund it yourself, whether you're going to have to go locally or a little bit further, where you can park or not park, whether people know who you are, who doesn't know who you are, whether you're getting the continuity of care you want or not. So what can you do to help yourself to give yourself the best chance? Now, I'm afraid to tell you this, but I need to speak to you a little bit about evidence-based medicine. Evidence-based medicine was a term that was coined in 1990. And it is that medicine, that treatment, that unequivocally is beneficial to you. So without doubt, if we give you a particular treatment, it's going to help you. Now, I will let you into another secret about doctors, nurses. I have never signed a contract, nor has any doctor in any hospital I've worked in, that says I must do good. What we say is we must not harm you. That's what doctors sign up to. First of all, do no harm. And you might think, oh, that's obvious, isn't it? And of course, in 2023, most of the treatments that we offer are of evidence-based benefit, but that wasn't always the case. You know, there are lots of things that we do that are not evidence-based. They might not be harmful, but they certainly don't do you any good. And that's okay too. But you've got to be aware that some things are of no benefit to you. You know, because humans, we love a good legend, we love a good story. Oh, that sounds good, you know. Hair oil with, hair shampoo with cis-linoleic or pro-vitamin B. They do no good whatsoever. It's never been proven. And if you look at the bottom, it'll say, bottom of the advert, 73 out of 85 respondents said they preferred it. Well, that's not statistics. That's just coincidence. So, you know, I believe in Robin Hood. I'm from Nottingham. I think he exists. I like me Lucky Heather and all your little rituals you do, certainly before my football team, Nottingham Forest, play. I can never listen to them on BBC because they won't win. Well, they don't win much anyway, but I have to listen to them on, my WhatsApp instead. So we all like that, but it spills over into medicine. Like, for example, reflexology. I love reflexology, but if a reflexologist says to you, "Oh, I'm going to rub this particular area of your foot and it's going to affect your hormones, it's going to double your chance of pregnancy," that's not true. It's not going to. How can you possibly rub somebody's foot and double your chance of getting pregnant? It doesn't happen. It's the same as sticking needles in you. But if that is going towards a complementary therapy, and the complementary therapist says, "Look, it's an old Chinese ancient art and it won't do you any harm, but you never know, it might just do you a bit of good," that's fine. That's okay. I'm happy with that. I remember once a patient wrote on Google Chat or FaceTube or whatever, and said, "I went to see Professor Kingsland. He's got magical powers. We only saw him once and we got pregnant." That is what I call coincidence. But I'll take it. I'll take the accolades. Yeah, I'll say, yeah, thank you very much. Yes, it was the supportive psychotherapy. No, it wasn't. It was coincidence. But we like that. And that's fine. You go into a health food shop and buy, alpha, beta, gamma, glutamate, placental transferase, enzyme, this, that, all that'll help you. It won't do you any good. But it won't do you any harm. And some people like spending money to make themselves feel better. My wife loves spending money on handbags because it makes her feel better. Well, that's fine. I mean, she's not wanting to get pregnant now, thank goodness, given her age. But, if that makes you feel good, provided you're in control, I want to spend my money the way I want it to. Fine, you do that. But don't be deceived. That's not going to get you pregnant if it's not evidence-based medicine. That's coincidence. So what are the evidence-based things that you can do? Wait. There is plenty of evidence to suggest that if you're outside the ideal weight, your chance of success go down. Well, you know, we all try and lose weight, and a patient came to me the other day and said, I know I need to exercise more. I know I need to exercise. I need to exercise more. I know I need to eat less, but I want the injection. There's no quick fix. You know, energy. The more energy you expend, the less your weight will come down. You know, patients will say to me, "Oh, Professor Kingsley, you know, I'm 18 stone. I don't eat a thing, and I've just put on 3 stone in weight." Well, that doesn't happen. It's not physics. You know, if you stop eating, you will lose weight, but it's not very pleasant, and it's hard to stop eating. But that wasn't, you know, nothing's ever easy, and you know, you get these weight loss pills and all this, and probiotics, and and people spend a fortune on that sort of stuff. But you've got to know that it doesn't necessarily work. It's not just because it's in a health food shop doesn't necessarily mean it's going to do you good, as long as it doesn't harm you. Now, if you're taking, you know, Chinese snake oil, because, you know, that might harm you, and that's bad. But if it doesn't harm you and you want it, up to you. But if you do get pregnant when you're doing it, that's coincidence. So try and get down to your ideal weight. Now, this is an obvious one, but there's more information coming out every day about sleep. Get plenty of sleep. Don't burn the midnight oil. Go to bed, you know, 10 o'clock, half 10, and get a good night's sleep. 1 hour, what is it? 2 hours, 1 hour before midnight is better than 2 hours after. Stop smoking. Smoking is bad for you. And there again, you know, I've got patients who will come along and spend a fortune on vitamins, minerals, and, you know, various potions and that, and be smoking 10 fags a day. That don't make sense. Stop smoking. It's not good for you. You know, it kills your eggs. It rots your eggs. It rots sperm. So stop smoking. Also, public enemy number 2 is sugar. We eat so much rubbish these days, and I work a lot now in the United States of America, and there is so much rubbish food readily available, and you can see it. You can see the consequence of that in people's weights. You know, 50% of adults are morbidly obese, not just obese, morbidly obese, and that really affects your fertility. Don't buy anything 3 meters from the checkout desk in a supermarket, because it'll ultimately depress you, whether it's a magazine, you know, or whether it's a bar of chocolate. Quick fix makes you feel good, but ultimately you get depressed. I mean, I was watching, what did I switch telly on last night? Emmerdale. It's all about misery, isn't it? It's all about misery, and you come away, you think, that's depressed, but we like to sort of wallow in other people's, you know, misfortunes, because that's what we do. But it doesn't do us any good, because what we need to do is to release dopamine. Dopamine is that happy drug that gives you positivity. It's the drug that the hormone that makes you think that something good is going to happen, and that has got to be positive. So try and be positive. Cut down drinking alcohol. Don't stop altogether. I'm not a hypocrite. I can't say that. But what you also have to remember is that alcohol gets metabolized in your liver to acetaldehyde. Acetaldehyde is nail varnish without all the ingredients and the colors. So when you drink, your liver can't differentiate between, oh, that's alcohol or nail varnish. It sees it as the same thing. So just keep it down a bit. Keep the stress off you. Off your liver if you can. Take your folic acid. There is unequivocal evidence-based medicine that for women, taking folic acid gives you a better chance of having a healthy baby than if you don't take it. I can lead you to the library and show you loads and loads of unequivocal evidence that proves that taking folic acid gives you a better chance of having a healthy baby than if you don't take it. Men, cool your testicles. Sperm like to be kept outside the body in the cool, not warm. So make sure the testicles are cool. Avoid hot baths. Don't crush your Don't crush your testicles on bicycle seats for hours on end. Don't take anabolic steroids, because that's great for your muscles, and it's great for testosterone, and it delivers sperm, but it's rubbish for making sperm. It's much better to be thin and weedy when you want to have a baby than all muscle bound. And you know, if I want to fill up my sperm donor clinic, I wouldn't go to a gym to ask for potential donors, because it's not necessarily good for your sperm production being muscle bound and being too fit. Yeah, exercise definitely, but not too much. You know, and when you're having your treatment, don't move house. Don't suddenly decide to go on holiday. I had a patient the other day who said to me, well, she just had a positive pregnancy test after IVF, and I said, what are you going to do now? She said, oh, I'm going to go to Lanzarote for a holiday. I deserve a holiday. Is that okay, Professor Kingsland? And I said, yeah, it's fine, but just answer me one question, right? You're on the beach and everything's fine, and you're happy and you're pregnant, and you think, oh, I'm going to go for a paddle. And you get up and you look on your beach towel and there is one drop of blood on your beach towel. What do you do next? Now, if you can answer that question and you can answer it positively, then you go to Lanzarote, go anywhere you like. But otherwise, if you can't, stay at home or go to Devon if it's not being battered by you know, Hurricane Kieran or Barry or whatever it is. Stay at home, just chill out, and concentrate on having your baby. And don't change jobs or decide to decorate or tarmac the front. Just concentrate on your fertility and on your treatment. And finally, one of the things about being a doctor through these 40 years is that I have seen many changes, and success rates now are much more predictable than they've ever been before. But it gets to the point after about 10,000 people, couples, individuals that come in, I know with a fair degree of accuracy who I think is going to get pregnant, and they do. And I know who aren't going to get pregnant, and they don't. I see some people who I don't think are going to get pregnant, and they do. And they're the odd ones that you think, oh my word, I don't know how that happened, but she got pregnant. And that's great. But the patients I don't see anymore, apart from very occasionally one or two, are the patients I think are going to get pregnant, and they don't. Because they've gone. Patients who you think are going to get pregnant do get pregnant. Now, the rate limiting step for that, if you're not in the NHS, is finances, because unfortunately we go back to the fact that IVF is not funded adequately, not in the same way like Denmark or Belgium, where you can walk in and get any number of IVF cycles on the national health, because on their health service, because that's the way their government is structured. So 10% of all babies in Denmark and Belgium are IVF babies, and that's the true number. In Britain, it's less than 5% because we are under-resourced. There should be more IVF babies because more people need that treatment. So the rule that I always say to patients, and those of you who've seen me in the past, is you've got to try and be in control. And what I do, there's the other thing that you need to do is the rule of 70. 70% of everything you do in life is determined by your ability to communicate. So your success at your job, irrespective of whether you're a brain surgeon, an astronaut, or anybody else, 70% is your ability to communicate. And also 70% of the happiness that you will have will be attributed to your partner. So indirectly or directly. So bear that in mind when you're choosing a partner. Just you think, not so sure about that one. But most of us, fortunately, when you come to a fertility clinic, are in the right partnership and you are happy and you're together and you support each other, because that is vital, supporting each other, because at times like this, the stress can be prohibitive. And finally, I say to patients, before you go out, draw a little square with six squares on it. 1, 2, 3, 4, 5, 6. And down the side, put time to baby in the first box, cost of baby in the second box, and chance of baby in the third box. And in that box, next to time to baby, I'm going to say, how long are you going to spend trying to have a family? You're in control. It may be 6 months, it may be 18 months, it may be 2 years, it may be 5 years. If it's 5 years, I would say that's a bit long. If it's 6 months, it's too short. So let's just say 2 years. I'm going to try for a baby for the next 2 years, and in 2 years' time, I'm going to come and see you, Professor Kingsland, and say, I'm done. That's it. And hopefully you're done and successful. But at least you've got a time limit on what you're going to do. The next box is cost of baby. How much money am I going to spend trying to achieve my goal? How am I going to budget it? Because it's absolutely vital that you are able to cost out your treatment and you're in control. You know exactly what you're paying for and exactly what you're going to get. And it's not too difficult to ask for. That's what you should do. It might be 5,000, it might be 50,000. If it's 50,000, I think it's too much. But most people should be thinking about budgeting 10, 15,000. Now, but everybody's different. You know, you might say, I want to save my whole life savings on it. Well, that's fine. So based on the time you're going to spend and the money you're going to the money you're going to spend, I will fill in the bottom bit. What is your chance? Now, it might be 75, it might be 80, it might be 10, it might be 5. But irrespective of what that chance is, you should be told before you start and be in control of your fertility journey. So at least you know that there's a beginning, there's an end, there is a beginning and an end to the finances, and you know at the end what are your chances, because not everybody's going to be successful. But at the end of the journey, what we want to say is, what I want to say is, I've done my best. There is nothing more I can do. And hopefully you've got what you wanted. But if you haven't, and you have done your best, but if you haven't, you can say, there is nothing more I could have done. I've done everything. You might be sad and you might grieve for the child you never had, but at least you've tried. Because the people that I find that do take that fertility with them as they get older, that fertility grief, is those who say, if only done that. I saw a patient in the last year who I remember quite vividly, and I said that IVF will cost you £6,000, £7,000. And a male partner, they were in a heterosexual relationship, a male partner said, 7,000 quid? Oh, blow that, I'm going to buy a patio. Well, great, that's fine. If that's what you want to do, go and buy your patio. Good, that's a good choice. If that's what you want to do that. But my concern is that in 2 years' time, when you're barbecuing your sausages and your beef burgers, your protein-rich beef burgers, and there's an empty chair next to the table, how are you going to feel? Now, if you say, I feel great, that's good, because you're in control. There's a lot of things that you can't control about fertility, a lot of things you can't control about IVF, but there are some things you can. You should be able to control how much you're going to spend, how long are you going to spend doing it, who's going to look after me, where am I going to go. Make sure that whoever's going to, look after you, makes you smile, makes you feel positive, makes you comfortable that you are doing whatever is best for you. Okay, and then finally, all you need is just a bit of luck, just that little bit of luck, that little bit of magic that I don't know where it comes from, and I've been doing this for 40 years, but it's there. And if you do everything right, then you get that bit of luck. You never know what might happen, because at the end of all this journey, there is still a bit of magic in it, and that's what makes it so addictive to me and makes it worthwhile doing. So that's what I wanted to say to you tonight. Good luck with your journey. I'm just going to go through a few questions in the last 5 minutes because I always run over. Sorry, Chloe, but you know me. I'm going to just go through what one or two things. Oh gosh, there's quite a lot. But anyway, is there anything I should consider for a cycle with donor eggs? Well, I've told you what you need to do with regard to fitness. Do your research. We have a big donor bank at Care Fertility. We are dedicated. We have 25 clinics across the UK. We're the biggest independent fertility unit, and therefore we've got lots of resources. We've got a donor bank that could suit you. We've got clinics that are dedicated to egg donation. So if you want further information and you can't get what you need off social media, give us a ring. Phone up Care Fertility. One of our Care Pals people will be able to put you in the right direction and give you the information you need to make an informed choice about what you want to do for yourself. Fresh versus frozen transfers, is one better than the other? Well, if you asked me that 15 years ago, I'd have said, yeah, fresh, because that's one of the reasons why because we couldn't freeze embryos successfully as we wanted. That's why we used to put more than one fresh embryo back, because we couldn't store them, and the more you put back, the better chance you got of getting pregnant. But the chance of having a live birth were not improved because of the miscarriage rate of if you got pregnant with twins or triplets, or heaven forbid quadruplets, which used to happen in the dim and distant past before we had the technology to put one embryo back successfully. Freezing embryos now is much more sophisticated, and I would argue that there are many advantages about having your embryos frozen, because going through the egg collection with all the hormones can be quite stressful and traumatic in itself. So why don't you take time out, after you've had your embryos created and the embryologist has phoned you and said, or you've had care maps with us and you've seen your embryos growing, and the embryologist says to you, you've got 3 beautiful blastocysts in the freezer, then go away and have your holiday and chill out and do your stuff, and come back a month, 2-3 months later and have your embryos put back. Because the chance of getting pregnant with a frozen embryo is every bit as good as a fresh embryo. So you might, you might prefer that, or you might want to get it all done within the first, in one fell swoop. I wouldn't personally recommend that. I think the future is frozen, and I'm open to criticism for saying that, because a few of my colleagues wouldn't agree with that. But if it were me, I'd have my embryos frozen. Recurrent miscarriage, should we get progesterone? Recurrent miscarriage, that's where you have more than 3 miscarriages on the trot. You get investigated. Go and see a recurrent miscarriage expert. Going back to Care again, we've got 61 fertility doctors dedicated to fertility, and we have within those 61 recurrent miscarriage experts, and we can actually speak to the experts on your behalf, and if we don't know the answers, then we can get the answers for you. Should we get progesterone? Yeah, get investigated first, get the proper investigations at the right time, but progesterone won't do you any harm, and there's some evidence to suggest that that additional progesterone can prevent the occasional miscarriage. So the benefits of taking progesterone for the first few weeks of pregnancy outweigh the risks. So I'm now getting waved at to say you've got to finish. So thank you for listening, and thank you for staying with us throughout the week here at Care Fertility with our care family. We believe passionately that family is for everyone, irrespective of gender and sexual orientation. So if you have a disease that you're concerned about, just pick up the phone, give us a ring. Even if it's for reassurance, it's, that may benefit you, 1,000%. Just to share that problem, it can be of great benefit. So, that's it. Thank you again for listening. Good luck and happy Thanksgiving, happy bonfire night, and hopefully we'll see you in the not too distant future. Bye-bye, everybody.